This episode of JNM Podcast is sponsored by Sophie Biosciences.
Hello, my name is Ken Herrmann. I'm a nuclear medicine physician based in Essen in Germany, and I welcome you to the 10th JNM podcast. And topic today is very exciting. It's going to be about metabolic PET markers beyond SVMin and SVMax. And obviously this is not my most convenient topic, and that's why I invited three very, very smart people to talk about it. And I'm very happy to introduce the first one. The first one is Irene Buvat. She's actually a fellow co-editor of the Journal of Nuclear Medicine. And in her day-to-day job, she is a professor of physics. She's a PhD as a background, and she's also director of the research unit Laboratory of Translational Imaging Oncology at Institut Curie in Paris, in France. Welcome, Irene.
Welcome. Thanks.
The second person is Professor Sally Barrington. She is not only a board-certified nuclear medicine physician, but she's also a professor of PET imaging at King's College in London. This is pretty impressive. I've never heard about a professor of PET imaging. I think this is as high as you can get in PET imaging. And she's also a professor of the National Institute for Health Research and Social Care since 2017. Welcome, Sally.
Thanks very much, Ken. Lovely to be here.
Thank you very much. And the third one joining us from Australia is Professor Louise Emmett. She's a director of diagnostics and nuclear medicine at St. Vincent's Hospital in Sydney, also called Vinnie's. And she's also a clinical professor with the University of New South Wales. Welcome, Louise.
Thank you.
We know that nuclear medicine has been, in the past, very much driven by the success of PET and FDG PET. And it's pretty clear that one of the prime indications, at least in Germany, making PET really accepted by clinicians is the use of FDG PET in lymphoma. Sally, I would love to ask you a little bit about, to summarize, how did you and your colleagues make FDG PET such a gold standard for lymphoma imaging? And then maybe also later discuss a little bit what comes next.
So thanks very much, Ken. I think it was really the very early days of PET, more than 20 years ago, that really we made the first sort of observations in the clinic that FDG PET was brilliant for providing a really quick readout of what was happening in terms of treatment response in lymphoma. And furthermore, it was much better than CT at staging, particularly for extranodal disease. And on the back of that, we started off just very simply assessing response visually, but then we started in the context of a lot of clinical trials, working out how we were going to be able to use FDG PET to adapt treatment, putting a large amount of effort into how we standardized both the way in which we acquired the PET and the way in which we reported it. And I think that's really has been key to being able to start to use semi-quantitative assessment. So we started then to sort of look at the uptake in lymphoma residuals and compare it to reference regions like the liver and the mediastinal blood pool, and to use the maximum SUV for that purpose. And that's the basis of the so-called Deauville criteria. They're called Deauville because that was the first international workshop on using PET for response assessment. And Irene and I are actually both organizers of the scientific committee. We're about to have the 10th one in Menton later this year. But that was really the sort of start of the Deauville criteria. And I think one of the reasons why the Deauville criteria caught on was because it was really simple and because it was very reproducible amongst readers. And then we took the Deauville criteria and we started to look at, well, how do things change between baseline and response? And as part of the Lugano classification, we incorporated those Deauville criteria in metabolic response categories. And again, that caught on, I think, because the hematologists were very familiar with those concepts from CT, and they could see how much better PET was in discriminating response. And the Lugano classification were actually published 10 years ago, but it still remains the standard of care today. And that's kind of the journey. That's where we have got to, but things are now moving on.
So first of all, congratulations not only on establishing really the Deauville criteria and putting this into relation with the Lugano classification, because it's really everywhere, I think, widely used as a clinical standard, but also congratulations on the choice of locations. Lugano, Deauville, Menton. You could do much worse.
I'm not stupid, Ken.
That's good. So now the big question is, you already hinted towards that you move on. So, and we of course want to talk about quantitative PET. So it's not very surprising that we will that you have an idea to leave actually the visual analysis of Deauville. So what are the next steps?
Well, I mean, I think SUV max is actually a very useful measurement. It's crude, but it is very useful, and it is simple, and it's very reproducible, at least amongst readers, provided you standardize the way, of course, in which you acquire the PET. In the Deauville criteria, it gives us a very high negative predictive value, and we can confirm remission. But what we're not so good at doing is the positive predictive value is not as good as we would like. And I think that's got worse over time. And the reason for that is that our camera technology has improved. And of course, the treatments have got better. So it's always more difficult when you're trying to find a smaller and smaller difference. The other problem is that we're intervening only after treatment has already started. And what we want to be doing is we want to be doing what I would call risk-adapted therapy. So using the PET right from the beginning, not just staging, that's really crude, to tell us more about what sort of treatments we should be offering, and it's particularly important in lymphoma at the moment because for the first time, really, we have some really exciting new treatments, particularly in diffuse large B-cell lymphoma with the T-cell engaging therapies with CAR-T and with bispecific antibodies. So we need something else. So what's next? I mean, maybe I could hand over to Irene to talk a little bit about some of the other markers that we're interested in developing. Irene?
Yeah, thank you, Sally. As you know, PET images also reflect very well the whole tumor burden. So the assessment of the whole tumor burden is much easier on PET images compared to CT or MR. And this total tumor burden has been known to be a prognostic factor for a very long time for many diseases, actually, not only for lymphoma, but also for lymphoma. And more recently, it has also been shown that the dissemination of the disease over the whole body is a prognostic marker, which is actually complementary to the tumor burden. That is, for a given tumor burden, the way it is disseminated in the body has some prognostic value. So these are, new biomarkers. Also, the metabolic tumor burden is not new, but we will come back to that. These are quantitative biomarkers that could be used for treatment management.
So Louise, you're more a prostate person, but both of us still read every once in a while lymphoma PET. When you hear these innovative markers, so how much time are you willing to invest into getting these markers?
Well, as you know, Ken, I'm a pretty simple person, and if I can press one button and it comes up on my screen, then that's what I need. But more than that, I report with radiologists and dual-trained radiologists every day, and I want them to be using the new techniques as well. I want them to incorporate them on a daily basis into their reports. And for them to do that, it needs to be automated. So I guess a question I've got for Irene is, how close do you think we are with lymphoma to actually being able to fully automate it and have an accurate measure of MTV in clinical practice without a lot of work?
I would love actually also to not only Irene, but also Sally comment on this. In addition, what data do we have to show that, do we have prospective data showing that these markers are really superior? And I think you can advertise a little bit your very exciting data which you have published.
Sally, you may start to explain the value, the actual value of TMTV, and then I can explain how we can make it fully automated.
So first of all, Ken, I think we started with looking at the methodology. So we started looking at the methodology, and Irene can expand on this a little bit more. But what was to come back to Louise, the simplest way to actually get a really good approximation of what visually we appreciate the tumor burden to be. And so we started really quite simply comparing different methods in the literature that had been published for different thresholds for segmenting tumor. And using various clinical trial data, we came up with a standardized method that we believe is the quickest and simplest to apply. And we were able to show that simply that all of them predict prognosis equally well. It doesn't really matter which of the published methods you used, but the one that was quickest, that's more likely to be suitable for Louise's push button, was using an SUV of 4 to segment the tumor, and not segmenting every tiny little area of tumor, but limiting the lesion size to 3 mils. And what we were able to show in a very large data set of about 1,700 patients with diffuse large B-cell lymphoma was that the metabolic tumor volume actually outperformed what's used as the standard clinical prognostic score, which is the IPI, or the International Prognostic Index. So we were able to show that the MTV was better at predicting progression-free survival and overall survival. And then what we did was we said, well, how about if we try and combine these? What are the factors that will, overall predict that survival in the best way? And we came up with a new score, which we nattily called the International Metabolic Prognostic Index. And it's composed of 3 factors: age, which reflects the biological status of the patient; stage, which comes back to Irene's disease dissemination, but very simple to measure; and the metabolic tumor volume. And importantly, we use the metabolic tumor volume as a continuous measure, age as a continuous measure, stage as 1 to 4. And then what we did was we have a simple regression formula that will give you the predicted 3-year progression-free survival for an individual patient, if you like. Now that sounds complicated, but it isn't complicated. You measure the MTV, and Louise, there's a simple Excel tool. You enter the age, the MTV, and the stage, and it will give you the 3-year progression-free survival for an individual.
Can you do it in your head?
No.
It's interesting, isn't it? Ken, I know Irene's going to talk just now, but when we come back to PET, can you remind us that we need to talk about SUV max of 4 as the minimum cutoff, because that's really interesting for comparing FDG and PSMA.
So the data you mentioned was so impressive that my hematologist came to me and said, when do we get this score? Which means, again, I need the MTV on a push button basis. So Irene, where are we there?
Yeah. So as just described by Sally, we came to an agreement on this simple method based on SUV greater than 4, and we even produced what we call a benchmark data set consisting of 60 PET scans of lymphoma patients, different subtypes of lymphoma, with the benchmark metabolic tumor volume that was agreed on by several experts. And this is online, so you can access this data and check that the way you measure TMTV is compliant with these reference values within a few percent. So we think this is a good step and an important step so that people can check that the way they can measure TMTV on their console gives the expected value compared to these agreed on values by an international committee of experts. Now, coming back to the explanations by Sally, once you get the segmentation of all tumor volume, you can calculate many candidate biomarkers, including a dissemination feature that is very simple, that is just the largest distance between 2 lesions. And you can replace the stage 1, 2, 3, 4 by something which is a continuous value and that will hopefully improve the prognostic value of your index.
I don't want to be too persistent, but my question is, all this sounds exciting, but still very complicated. So I know you have activities making these tools automatic, included into some of the vendor-specific software. Where are you with this effort?
So can I just say that from my perspective, that using this particular method in 80% of cases we were able to show, in fact, it was published in the JNM back in 2021, 80% of cases you can get a measurement of a metabolic tumor volume in less than 5 minutes. It's not push button, Louise, but it's 5 minutes. That's probably, in terms of, for me, it probably takes me half an hour to report a scan. So an extra 5 minutes, I'm willing to invest that. In a small percentage of cases, it takes longer. And that's where I think we need smarter solutions. So I'm coming back to Irene for this.
Yeah, so now you are probably aware that we have more and more artificial intelligence-based segmentation tools. By the way, for FDG PET, but also for PSMA. These tools are coming. They are published. They are now, we have some results that are very encouraging, showing that they can reproduce quite well, the expert delineation of tumor volume. So the future will be the use of these tools, and then we will get to the one push button that you dream of, Louise.
So Louise, on PSMA, we already made some effort. Maybe this is a perfect handover to mention. What do you think about PSMA PET and automatic segmentation? What parameters do we use? Do you want to mention SV of 4 as a cutoff? And what about one pot brush?
No, not 4. So that's something I think is really interesting, and I want to ask a question first, and that is that metabolic tumor volume is that taking over from Deauville in terms of intensity above, below liver? Is SCV max dead, or it's a composite? So you use both?
Yeah, you use both. I mean, at the moment, the metabolic tumor volume, that is for baseline, because obviously we have
Prognosis.
very high contrast. Yeah, so it's used for prognosis or risk, I would call it risk, potentially for risk adapted treatment. And we have trials starting with that. Whereas the Deauville criteria is still relevant for response adapted treatment, although we can certainly improve on that with other radiomic features, I think.
Yeah. So I think it's really interesting talking about PSMA and FDG, because in fact, when it comes to, you almost have to turn a little bit on your head with PSMA, what we're doing in FDG. So when we looked, and there's been about 5 publications now, be happy to know that most of them are in JNM, Ken, and they're all showing that change in volume is very important. So an increase or a decrease in volume is extremely important in identifying progression, but change in intensity is not. So all 5 studies have shown that a change in SCV mean or SCV max is not predictive of outcome. And that's because we're using PSMA PET to look at treatment response, often in a PSMA targeted agent using lutetium or actinium. And so it's actually impacting what you're seeing. You get a reduction in intensity anyway. And then, so this change in volume looks like it's very important. But the other thing that's super important is, unlike with lymphoma, in lymphoma, as it gets more aggressive, it gets brighter. Quite often your very aggressive clonal populations in PSMA PET will be less bright. Some of them will have an SCV max of 3 or 4 and will just spread like wildfire. And what you notice is the intensity is going down, but the volume is going up. And that is a very, very nasty clonal population that you see. So if we have an SCV max of 4 in PSMA PET, we will be missing a proportion of patients who have very low PSMA expression clonal expansion, which is very, very poor prognostically for that patient. So tumor volume, we have to be very careful not to use too high an SCV max, so we don't miss those patients who've got clonal expansion, which is low PSMA expression. So I think we should be down about 3, clinically we say above blood pool, but I think an SCV max of 3 is quite good. And I think we're going to find metabolic tumor volume is going to be just as important in PSMA PET as it is in lymphoma, and then the intensity scores are going to be less. But they'll be prognostic, but they won't be for treatment response.
I mean, the differences are not very surprising, right? One is a metabolic marker, no. FDG metabolism, the other one is a receptor expression marker. My question would be now, you propose 3 as a cutoff, or how would you what would you use as a cutoff for defining PSMA positive tumor volume?
Yeah, it's interesting because you don't want to miss those low expression cells. And then at what stage do you have, say, sclerosis in a bone, which is inactive disease? Because what happens with prostate, it also happens with breast, is if you treat the disease, the lesion becomes inactive but sclerotic. So you see it on the CT. So a lot of people are looking at these things on the CT. You have to decide whether they're active or inactive. So you need a threshold, but you need a low threshold. So I guess we need to decide, where are we comfortable that we're looking at something that is inactive versus active, but low expression.
So we just hit the 20-minute mark. So I have two questions. The first question is, why would we still use absolute cutoffs and not relative ones? Because technically different tracers, different scanners, whole body scanners, different acquisition times. This is my first question, and this actually goes to Sally and Irene, because you have a lot of expertise there in lymphoma. And the second question, of course, is, and I want to ask all three of you, how can we make these automated softwares widely available? Louise, we have one dedicated company we work with very closely. We try to bully them, but we probably have to bully all of them, right?
Yes.
Yeah, I think you're right, Ken. I think the most important thing is the interaction with the vendors. I mean, there are some very nice publications, some by Irene's group, for example, Capobianco, I think was JNM 2021, but also Jamar and colleagues using AI solutions for both risk and response assessment in lymphoma. And in fact, it's very interesting because if you look at these publications, they predict response or prognosis, as well as those of us who are reading the scans, and maybe there's a hint that they're even slightly better. So I think it is important to engage with all the vendors. I think they are actually very keen themselves to take these forward, and I think the best thing is to have that interaction between all of us. In terms of your absolute versus thresholds, as I said before, both work reasonably well, but in terms of simplicity with lymphoma, it's much easier, Louise, because I started measuring SUV 2.5. Irene knows this. I was a great fan of 2.5. I was much more of a fan of 4 because, of course, it cuts out the liver and a lot of areas of physiological uptake. And what I would just say is that 4 works very well at baseline, obviously doesn't work so well at response. And one of the things we've been looking at is actually using a so-called majority vote approach. So you can actually measure the lesions in various different ways. So using, Ken, both absolute thresholds, using percentage thresholds, and using adaptive thresholds. And then what you do is you look at the pixels that perhaps 2 or 3 more of those methods interact or select, and that will give you your best representation of the volume. It's not one button push though, Louise, at the moment. It's actually quite cumbersome. But I do think, and this is one of the reasons I'm always so keen to engage with my physics colleagues like Irene Buvat and Ronald Bouillard, to make these solutions ones that are fit for our academic purposes, and then to engage with the vendors so that they are commercially available.
Yeah.
Irene, you want to add something?
Yeah, I think we will progressively move away from absolute cutoff values, to decide whether it's tumor or not. The 4 that Sally was mentioning, the 3 for PSMA. We won't use that in the near future. We will use these AI-based algorithms that are able to adjust the threshold or to delineate tumor by accounting for the spatial resolution in the images, because you know that with the most recent detectors, you have higher SUVs because the spatial resolution is better, you have less partial volume effect. And the beauty of these AI algorithm is that if you train them with a huge variety of PET images, they learn to adjust their threshold or their delineation to the spatial resolution noise content of the images. So I really think this is the future, And we have to work with the companies so that they provide enough evidence that their algorithms are good enough. So we have to work with them, but they are very interested in providing you with these tools to make, quantitative biomarkers used in the clinical routine. So you have to go on asking them.
It's interesting though, isn't it? Because if you use an AI tool and you have a lot of variation in how each company does their AI and they want to hide how it's done so that everything's a little bit different, then you can only look at a patient serially with exactly the same tool. You can't use any other tool, else your volume will be very different. And if we're comparing different volumes between different vendors, does that then get different if you're using the AI? Yeah, I take your point entirely on the minimum cutoff, but it is difficult to make sure that we're measuring the same thing.
But Louise, that's the beauty of the benchmark. That's why the benchmark is so key, because we have all these AI tools and we can compare them to the benchmark and say, do you know what? They measure them in the same way. It might be that it's, software firms A solution or software firms B solution, but provided they can all be compared to the same benchmark, we're okay. And what I would say is that whilst we're waiting for this to happen, Ken, please do try and have a go at measuring MTV for your hematologists, because that's the other thing that's going to make the software vendors keen to do it, is if they've got the prostate cancer oncologists and they've got the hematologists in lymphoma saying, we need this.
These are beautiful last words. So let me conclude. So first of all, thank you very much for the pioneers of metabolic tumor volume in lymphoma, Irene, Sally, and of course Ronald, who couldn't join today. Thank you very much, Louise, for promoting the one button push. I think this is super, super important. It's also very clear that this is a very important topic. We have not all answers yet. So I think there will be a follow-up podcast, hopefully in a couple of years, hopefully months, but potentially years. And last but not least, I want to actually highlight a lot the next Monton conference, because as people are able to retire in the UK with 50 years, it's going to be Sally's last conference. And who wants to see Sally in action? She told us it's an opportunity to see her one last time in Monton in September. Is this correct?
That's correct, Ken. Yes.
So,
yes.
Don't miss out. And it's a beautiful place as well, as you can imagine. Sally is not stupid. You heard this.
www.lymphomapet.com. I think that's right, isn't it, Irene?
Yeah.
Super. We will put it also in the captions in case you're interested.
That would be lovely. Thank you.
Thank you very, very much for joining. Thank you very much for all the listeners tuning in. And again, I think this was super exciting. Thank you.
Thank you for the opportunity, Ken.
Thanks a lot. Bye-bye.
Thanks for watching, and thanks to Sophie Biosciences for sponsoring this episode. Please remember to like and subscribe.